There's a lot of anger and consternation in the world of COVID policy. Some people are having difficulty with us removing restrictions. They want us to keep mask mandates in place, though we allow indoor dining and large sporting events. Other people would want us to allow those large sporting events, but lose the indoor masking, and people have different feelings around kids. I think so much of the confusion boils down to the fact that people don't have a simple framework to think about COVID restrictions and rules and policies and interventions. I offer you one framework to think about it. There are three categories of things that will allow you to delineate all the noise in this space. There are, one, things we do to lower the risk of a bad outcome when you inevitably get infected with COVID. Two, there are things we do that delay the time until you get infected with COVID. And three, there are things we do that make us feel good, that allow us to signal to others that we want to fight COVID, but don't even work to delay the time until we meet COVID. So let's run through these three things. Number one, things we do that lower your risk. Vaccination is the biggest thing you can do, modifiable, to lower your risk of bad outcomes when you meet COVID. John Ioannidis has published a very nice paper on conditional probability of bad outcomes, but long story short, even if you're vaccinated, you may have a breakthrough, but you won't have severe disease, hospitalization, and death at the same rate you would if you met the virus without vaccination. It's probably the single biggest risk reduction you can do. Now, of course, losing weight, improving your medical condition, those are other things that are within your control. But a lot of the risk factors for COVID are outside of your control, like your age. You can't make yourself younger. So we should optimize our risk portfolio for when we meet the virus, we have better outcomes. And the other thing that goes in this bucket are the treatments we've had. Now, many treatments have been offered, maybe even thousands, tens of thousands. A very few number of them actually work in well-done randomized controlled trials. Those are the ones that we offer. That's largely within the purview of the medical system. There's lots of talk about Paxlovid, but I think that needs to be placed in the context of the clinical trials that have been published to date, which have been largely in the unvaccinated population. But let's set the drug question aside. Vaccination is the biggest thing you can do to lower your risk of a bad outcome when you meet the virus. The second bucket, things you do that delay the time until you meet COVID. There are lots of things you and we've all been doing throughout this pandemic to delay the time till we meet COVID, like spending a lot of time in your house, cloistering yourself away from society, wearing a high-quality respirator when you're in a high-risk situation. If you do that perfectly well, fit-tested, ideal circumstances, yeah, you might delay the time until you meet COVID. I'm sure that those efforts delay the time to meet COVID. But does it make sense? Now, it makes sense to delay the time until meet COVID if you can do something in the first bucket in the meantime, like get that vaccine. But once you've done everything you possibly can to lower your risk of a bad outcome, if you want to live and interact in this society, you're going to meet this virus sometime. Maybe not this year, maybe not next year, but soon. And for the rest of your life, you'll meet it again and again and again. And so if you plan on spending 20, 30, 40, 50 years on this planet, you're going to be repeatedly infected with SARS-CoV-2, the virus. And so it doesn't necessarily make sense to me that you would ostracize yourself from society to try to avoid something that is an inevitability, and that, if anything, your risk factors are only getting worse because you're getting older. The third bucket are things we do and continue to do that we think delay the time until you meet COVID, that don't do anything. And there are so many things in this bucket. I mean, we closed ice skating rinks in Canada, toboggan runs in Canada. We wear cloth masks, which have failed in randomized controlled trials. Bangladesh has a total null effect for the cloth mask arm. The point estimate is exactly the same as the no mask arm. Cloth masks do not work. They wouldn't be expected to work. You can go read what Michael Osterholm has written about this topic. They have very low levels of credible evidence. Extending that to children, to 2-year-olds, 3-year-olds, 4-year-olds, which is ironically the last vestige of sort of COVID restrictions, that's very irrational. That's unlikely to do anything. It's not even going to slow the time until they encounter the virus. Thankfully, for young kids, the odds are their risk portfolio is very, very low. The risk for a young child may even be lower than middle-aged people who are vaccinated or boosted or triple vaccinated. And so I think that's not the place that we should be focusing our energy and anxiety on. Many healthy kids have already had COVID-19. The CDC, prior to Omicron, acknowledged a seroprevalence of 50%. It would be great if we could test and tell parents that so they could feel even more reassured about the good outcomes for kids. But there's so many things we do that we think will delay COVID. We continue to wear masks outside. It's going to just delay the time until you feel the breeze on your cheek, but it's not going to keep COVID at bay. We wear the mask from the table, from the door to the table, but not at the table, and then go into the bathroom. This is a theater. It's always been a theater. It doesn't even make sense. We let Kyrie Irving stand there, but he can't stand there. He can't hold the ball, but he can't go in the locker. I mean, this is all nonsense. We do so many things in this bucket that it's no wonder public health has lost all credibility. It isn't Joe Rogan. It isn't people on the internet. It's public health itself have recommended, and public health advocates and proponents on social media and elsewhere and media interviews have recommended things that didn't do anything. And worse than that, they are proving that they're not scientists because they have run very, very few cluster randomized trials to figure out what actually works and what doesn't. So not only do we have these two buckets, things that delay and things that don't even delay, but we have very difficult time telling apart which is in those buckets. Not even know for sure all the things, which bucket they fall, because we've done very, very few credible studies. But that's how you need to think about COVID-19. It is now and forever a virus that will circulate among human beings. You cannot stop it. It cannot go to zero. That was very clear early on, obviously, but some people didn't want to see it. It's circulating in animal reservoirs. It's very likely that it'll jump back someday. We're all going to meet it many, many times in our lives. You fix the first bucket and you get on with life. That's always been the answer. That's why I've been writing policy papers that have said that much since January of 2021. We're now 1 year after a mass vaccination effort campaign, and we still have people who are scared to go to classrooms or travel or do all the things they want in their lives. Now, there are certain very select scenarios where people are suffering from transient immunosuppression, where I think that makes a great deal of sense, and those should, of course, be discussed with an individual physician. But there are a whole bunch of people on a big spectrum of risk that really have to face a choice, which is, when do you want to get back and participate in society? Now, some people say that they use cases or wastewater data to decide when they wear an N95, when they go to a restaurant or not. This is a great, an elaborate theater that you think is going to be in the second bucket, delay the time till you meet COVID. But don't forget, you're going to meet COVID eventually. And it's very likely that this sort of special algorithm you've created for yourself is totally fraught and won't work. If you are somebody in the business of studying medical algorithms like this, you would see that many, probably most, the vast majority have failed and don't even work. And so I suspect that your algorithm provides you sort of the illusion of knowledge, the illusion that you have more data, the illusion that your life is in your control, but it's just an illusion. You will inevitably meet the virus, and you're going to probably do well if you did all the things in the first bucket. That's it. It's just that simple. Do the things in the first bucket, decide for yourself when you want to get on with life, maybe take it easy on the things that probably don't do anything, take it easy on what other people should do. That's probably the most sensible path forward. And, there's no grand secret here. It's always been just like this. And actually, the biggest mistake I think that this administration made was they didn't acknowledge that vaccination was that big risk-reducing event, and that afterwards there was not going to be any sort of magic thing that was going to happen. You can give a fourth dose if you want, if you believe the data. And by the way, the data is deeply confounded. But if you believe the data, what that might do is it might further delay the time until you meet the virus. I doubt it will have much of a further reduction in severe disease and hospitalization for sort of most healthy, middle-aged, or younger people. That's yet to be proven, just as I doubt that for boosters, just as Paul Offit doubts that, and Marion Krause and Phil Gruber doubt that from FDA. So I doubt that that's going to make much of a difference in the first bucket. So if you're waiting for that fourth dose or the fifth dose or the seventh dose or the 12th dose before you get back to life, that's not going to be some magic dose. If you're waiting for the Omicron-specific variant vaccine, I don't think that's going to be sort of a magic further risk reduction. We've already seen near log-fold risk reduction from the vaccine. It's really good. I mean, you look at this conditional vaccine effectiveness paper by Ioannidis, you'll see for the probability of bad outcomes contingent on getting sick, the protection is still remarkably good. And so it's probably not going to get a lot better. Biomedicine is always plagued by saturation effects and things of this nature. So I don't know what you're waiting for. I don't know why you're angry with the op-ed writer of the day who says now's the time to drop restrictions. Everybody has an arbitrary line in the sand. I mean, unless your point of view is, and I've not seen anyone advocate that we should all just stay in our houses without going out. We all have different lines in the sand. Some people say it's okay to go to the movie theater, but wear the mask. But if everyone in the movie theater is wearing a cloth mask and the movie's 2 hours and there's poor ventilation in there, what do you? I'm pretty sure that's not going to do that much. You're in this bucket of theater, elaborate theater. And you're drawing the line elsewhere, because if you really were strict, you wouldn't even allow people to go to the movie theater. You'd advocate for them to stay home. So everyone's drawing the line somewhere. But the best way to think about it is lower your risk of bad outcomes when you meet this virus. Do things that delay the time to meet this virus until you maximize the first category, but beyond which, there's no gain because you're going to meet the virus eventually and you're not getting any younger. And then the third bucket is the theater, which is probably most things we do. Why is that the case? I mean, I don't think people realize, but most things in biomedicine and the history of biomedicine are in the theater bucket. Most things, the pretest probability a new drug, a new promising compound works is in the toilet. The pretest probability a new quality and safety metric works is in the toilet. The pretest probability that, you can be checking wastewater data and decide when or not to take off your N95 mask and hold your breath while you drink water at the nursing station. The pretest probability that those interventions help are in the toilet, because in the messy real world, they tend not to work in well-done controlled experiments for many, many years. Don't believe me? Read the book Ending Medical Reversal. It's the history of medicine. So, on that positive note, until next time.